Alright, so back again here with our 20th lecture in our series on the chest radiograph. This is going to be a lecture on the pneumothorax, a topic that we've mentioned multiple times sort of in passing over the last series of lectures, and now we're going to go ahead and explore this pathology in more depth. Let us begin first by refreshing memories on the various locations of normal and abnormal air in the thorax. You may remember this from the prior lecture. We took a cross-sectional slice through about the middle of the chest here just to explore this anatomy a little bit easier. I'll blow this up just a little bit. We talked about the various locations that air is normally located, or where your sources of air can come from, and the obvious one is the lungs, and air gets into the lungs through the trachea and the bronchi. There's also going to be air within the esophagus, when you're swallowing, and also belching, these kinds of things coming up and down, and of course there's air in the GI tract. Alright, and then we also talked about where air can go pathologically. So highlighting here in the blue, air can enter the pleural space, that potential space or space we don't usually see on the radiograph. It does have a little bit of fluid in there, but we can't see that usually. But if we've got some air in there, that's one spot that it can go. That's called a pneumothorax, of course. And as we discussed also, air can pathologically enter the mediastinum. That's called a pneumomediastinum. And then the last location, which is the least common, the one that people don't think about, is air around the heart and the pericardial sac, the pneumopericardium. And the pneumomediastinum and pneumopericardium were topics of discussion in our prior lecture. We're going to be focusing primarily on the pneumothorax. In general, there are two categories of causes for pneumothorax, and I group these sort of as the spontaneous types, like this, and in general, or the most typical scenario, is that we've got a healthy young adult, usually in their 20s or 30s. It's more common actually in men, by a couple of factors, maybe 3 to 1 or 4 to 1, something like that. What happens is there is a rupture of a subpleural bleb. So if you can think about sort of air sac here immediately adjacent to the pleural membrane, and that thins the pleural membrane because the little dilated air sac is sort of right against it, and because it's thin, that constant pressure that's happening there from air inflating it and deflating it, it can occasionally spontaneously pop. And if it does that, get a little bit of air into that pleural space, and sure enough, you'll get a small pneumothorax. And these blebs are almost always apical in location. So you end up, like I said, with a small pneumo. And of course, those things aren't colored orange in real life. It's going to be more lucent or darker relative to the lung, to sort of exaggerate that, sort of put that idea in your mind. And we'll talk about that in more detail later as we progress with the lecture. Now, these things don't have to be from blebs. They can be from some other causes too, like, for example, if you had a cavitary pneumonia, cavitated here, and that thing ended up damaging the pleural lining, rupturing there, could end up with a hole, again, creating a conduit for air to pass from the lung into that pleural space. Another possibility is if you had a malignancy that was apical or pleural-based. Doesn't have to be apical, can be anywhere along the pleura, and that invaded into that pleural lining and eroded it, get hole there, again letting some air out, another pneumothorax. And then cystic lung disease, the common one is the central lobular emphysema, the one that smokers get, and that's apical predominant. There are other more rare cystic lung diseases, LIP, Langerhans, Lamb, kinds of sort of random weird stuff, but most commonly emphysematous lung that's got these cystic holes in the lung there. That's also, if they're against the pleura, one of those things can weaken that pleural lining and pop spontaneously, just like a bleb. And sure enough, there you go, another pneumothorax. So that's the idea for spontaneous pneumothorax. And then the other category is, something like this, right? So trauma, penetrating trauma or closed trauma, stabbing or bad car wreck or motorcycle wreck or something like that. But there are other kinds of trauma that happen around the hospital, stuff like this, digging around in there, subclavian approach, trying to get a central line started on somebody in a stressful situation. It is one of the risks of that line placement is to damage the pleura. As we put that line in there, that goes in fine, but unfortunately we caused a pneumothorax. So post-line placement, of course, is a common situation. Some other things that would also fit into the traumatic category, as sort of I like to group them that way, are the 2 or 3 things that we discussed in the prior talk as potential causes for both a pneumothorax and a pneumomediastinum. So the first one we discussed was in a patient that was on positive pressure ventilation, but this could also be an asthmatic patient where we've got air coming in here forced, and the pressure within the alveoli, not necessarily at the pleural edge, but just sort of randomly in the middle of the lung, can end up, that pressure can be too much for it. It can pop, and then you'll get dissection of air along those fascial planes that goes back to the mediastinum, and then we end up with air in the mediastinum, but also dissecting along that lining into the pleura. So you can see both a pneumothorax and a pneumomediastinum. And then the other one that we talked about was if you have a tracheal injury or an esophageal injury. Both of those situations can cause air to leak out, and they can enter not only the mediastinal anatomic location, but also through that mediastinal parietal pleura, entering the pleural space. So you can end up with a pneumothorax there as well. So those were the 2 causes of both pneumomediastinum and pneumothorax occurring at the same time. I mention this and sort of go on and on about various causes because I want you to remember, like, your pretest probability. Is this a patient who could develop one of these things? Because as you're going to see as we go through this talk, that the findings for pneumothorax when they're small can be subtle. So if you have increased suspicion, you spend a little bit extra time looking in those target areas that we're going to discuss now a little bit closer. So what does a pneumothorax look like? Well, it depends. What does it depend on? Well, it depends mainly on the position of the patient. So in this situation, we've got an upright patient, and we're going to talk about that first. These tend to be the easier ones to see, even though they can be subtle when they're small. So you may remember this from a prior lecture. Talked about how, if we have an injury to the pleura, be it spontaneous or post-traumatic, get a little bit of hole there, and then that's going to allow air. It can move from the airway through the lung into that potential pleural space. And I'll notice that it localized at the very top there. That's because it's going to float, right? It's going to rise. And that's the principle for location for all of these things, too. So when you got an upright study, you're going to want to look right at the apex first. Typically, it's going to be more black than the adjacent lung. And if we go all the way back to our first talk here, remember that things look the way that they look on a radiograph because of how many x-rays they block, and air in the pleura is going to block less x-rays than air in the lungs, because even though there's a lot of air in the lungs, there's also the architecture of the lung that is sort of a little bit of soft tissue density that is going to block some x-rays, but that's not going to be the case, or it is to a much lesser degree when we've got air in the pleura. Alright, so besides being apically located and a little bit blacker than the adjacent lung, there are a couple of other things that I want to mention. So let's have a closer look here, and I'll point those out. One is this thing right here, that white line, a pleural line. This is very important. I'm gonna perseverate on about this as the lecture goes on and when we talk about the cases. So that's a key finding, especially in the setting of an apical upright pneumothorax here. So we want to see that white line, and I want to point out that that line doesn't do this kind of stuff. So it doesn't run off the side of the patient in that direction, or off the side that way, that it's sloping, curving with the contour of the lung at the apex there. So you don't want that white line to come off the patient like that, because that pleural line can't do that, right? So when you see that, you're like, maybe that's not a pleural line, maybe that's a bed sheet, or maybe that is a skin fold or something like that. So we don't want to see it go across the skin and run off the patient like that. That can't happen. It needs to follow the contour of the pleural cavity. All right. So another thing that you will read or you will hear is people talking about lung markings, and specifically no lung markings in that area there, like the hyperlucent area, the area that you think is a pneumothorax. People say you shouldn't see any lung markings there. But what if you do? What if you see one or two lung markings, a little bit of lung markings through there? Does that mean it's not a pneumothorax? I want to back up and just say that this rule is true. You shouldn't see lung markings there. But it's not a hard rule. There are exceptions. And so I kind of call this a soft rule. Why do I call it a soft rule? Because remember that the pneumothorax is a three-dimensional structure. The lungs, these things are three-dimensional. And what I mean by that, so if we look at our chest here, remember the blue would be the air and the pleural space. That would be our pneumothorax. But what if we just have the air that's distributed at the top here, or air that's just distributed at the back here? You can imagine that if it didn't go all the way around, that you could see lung markings through that, right? So anyway, there can be tricks. So it does not always hold up. If you see it and it curves at the lung apex like a pneumothorax is supposed to, if it's got that white line, it looks just like it's supposed to. If the patient's pretest probability is not zero, in other words, they're somebody that could have this and it's fitting clinically, you should not be like, no way, it's got lung markings. That's a mistake. Don't do that. And we'll talk about how you can prove it here later in the lecture. So hard rolls. I want to see that white line. I want to see it curve at the apex. I don't want to see it running off out into no man's land across the chest. Soft roll, void of the vessels and lung markings in that hyperlucent area. That's a soft roll. It's certainly helpful when present, but if you do see a few vessels, doesn't exclude a pneumothorax. All right, so let's pivot to the supine position. Same diagram that we had before. Lay the patient down here. Now that air that was previously in the apical position is going to redistribute to the most anterior spot. Now, why is it going to do that? Well, just like before, the same general principle, air is going to rise, and this time as it rises, it's going to rise to the most anterior position of the chest, which is the highest spot. And it's not going to stay in a blob like that. It's going to sort of spread out, layer out more like that. And when we discussed this originally in the prior lecture, I tried to make a big deal about how the highest part of the pleural space is actually at the lung base, right underneath of the inferior surface of the lung there. So that is going to be where the air goes to. And of course it's not colored like this, right? It's grayscale. So that's going to be the spot that we have to look. So what you're going to look for is a blacker or a darker upper quadrant in the abdomen. This is actually a little bit easier to see on the right because we've got the liver there, but you can also see it on the left. And that's going to be that air collecting at the base of the lung, sort of like we showed on the prior slide of that cartoon. You can also sometimes see a sharp outline of the dome of the diaphragm, again because that air is giving them an interface, a little bit of contrast there. Another finding that is sometimes helpful is air situated in that lateral costophrenic sulcus, which is going to be the most lateral and the most inferior aspect of the pleural space. So it creates like the appearance of a deep sulcus. That's sort of the buzzword. It looks like it goes down further on that side than it does on the other. And then another thing that you can see that we talked about a little bit in our pneumomediastinum lecture is a sharply defined cardiac border, or sometimes a sharply defined pericardial fat. Alright, so as a review, we've got our supine and our upright study here, cartooned in grayscale. On the supine study, we can see that air creating that sort of deep sulcus appearance, maybe a sharp diaphragm or a sharp border of the heart. The dark part is going to be at the base of the lung on the supine. On the upright, the dark part is going to be at the apex because the air is rising. So let's do some practical cases here, play a little bit. So this first one is a line conformation case. So this patient has had a subclavian approach, central venous catheter placed under stressful conditions. Alright, so sure enough, there's the line, tip of the line right there. But we remember from earlier in the talk when we were discussing sort of the different categories and causes of a pneumothorax, I talked about trauma being one of the big categories, and not just being stabbed or shot or some kind of a closed trauma, but also iatrogenic stuff, particularly line placement. So we know that that's a possibility, so we're going to ramp up our sensitivity. These findings can be tough. Pneumothorax can be tough to see. So it's really important that in your mind you think to yourself, is this a patient who could have a pneumothorax? And if the answer is yes, you're going to have to zoom really close up, wrinkle your forehead muscles and squint tightly and really try hard. So if we're going to look anywhere, we want to look in the apex, right? And the reason that we want to look there is because we know that air is going to rise, right? We know, of course, that we're going to stare primarily on the right side because that's the side that the line was placed. So let's take a close look here, really look tight here. I feel like that I see something right here. Pretty sure. We should zoom up maybe even a little bit closer and see if we can tell. So remember that we had sort of a hard rules and our soft rules, and the hard rules that I talked about were trying to find that thin pleural line. I feel like I can see that right there. We'll zoom up even tighter here in a second just to be sure. The other hard rule, remember, is that we want this thing to sort of be shaped like the chest, right? Not be running off the side of the chest out in no man's land. That if that is the pleural line, it should be in the in the thoracic cavity, and that's where it has to stay. The soft rule that we discussed before was a void of vascular markings in the more lucent portion. So let's zoom up here and we'll see if we can see that pleural line a little bit better, and maybe if we think that we see less vascular markings. So we'll get rid of this magnifying glass, and sure enough, I feel like I can see a thin white line there. this is a very classic look for pneumothorax, very clean. And I think also, if you squint, you may be convinced that there is sort of a relative void of these very thin vascular markings in the more lucent part of the chest. Remember, that's a soft rule. If we saw one or two there, we wouldn't say there's no pneumothorax, especially given the fact that pretest probability is excellent. He just had a line placed on this side. We've got a pleural line here. It's following the contour of the chest, and we feel pretty confident calling this one positive. Let's take a look at another case. This one is even more subtle. You can probably see maybe thin pleural line there, again following the contour of the chest wall. I'll tell you that this patient had a history that was appropriate. Now I want to show you a couple of strategies and some tricks that I use that I think are useful when I'm really looking hard for these things. Most commercial PACS systems will allow you to invert the image. What does that mean? It means something like this, where you hit the inversion button. It could be different depending on the PACS that you have. And anything that's black will be made white. Anything that's white will be made black. And I guess, at least for me, I feel like you sort of grow up learning to write with black colored pencils and pens on white paper, so I'm sort of used to seeing black stuff on a white background, and maybe that's why I feel like it makes it a little bit easier for me to pick that up. We'll zoom on even further. Maybe you can see that sort of thin black line. It's not helpful for everybody, but for some people, they really get a lot of utility out of that particular technique. So that's one strategy. Here's another, turning the study horizontally. For whatever reason, human brain predominantly likes to see horizontal lines over vertical lines. There's actually an entire collection of optical illusions called after image illusions that work on this principle. You can Google after image optical illusion and play around with those if you want. I'm not going to dive into how that works like I did with the mock lines, because I think it's less important to understand sort of the why on that. Just know that it is sometimes helpful to turn the image sideways to sort of make some lines jump out at you. And this isn't like black magic or whatever. This is like a real thing with like neuroscience backing it up, that your brain actually does prefer to see horizontal lines. And we'll talk about that a little bit more when we have our lecture on finding rib fractures. But sure enough, there's our line. Sort of zoom in even more, prove it to you. There it is. All right, now here's the last thing that I want to discuss. Is there's a lot of stuff going on there, right? There's a lot of lines. We got a lot of ribs. We talked previously, very, very early in one of our talks about anatomy, about the scapula, and also about this thing called a companion shadow, and I'm going to review that briefly towards the end of this talk. But you may say to yourself, man, I see a line, but I see lots of lines. How do I know that's the pleural line? I like to use, the terminology that it was taught to me was dissection, or radiology dissection. And what that means is I'm going to trace each thing that I see. So I'm going to trace some of these ribs out, each one of these things. I'm going to trace some more of them there. And if you do that, you're like, okay, that line's a rib, that line's a rib, that line's a rib, that line's a rib. We could also trace out the clavicle, or anything that, the scapular border, all that stuff. And once you've sort of explained every line, if you've got this blue one left over, that has to be explained, then you have to be like, well, it's not a companion shadow, it's not a rib, and it's not artifact, we're pretty sure, based on the morphology. Again, we'll talk about how to tell artifact from an actual pleural line in just a minute or two. Then you have to call it. So that's the last strategy that I use there. All right, so let's play a little bit more, and this time we'll do some more challenging cases. This time we'll talk about a few studies that are done in the supine position. All right, so remember that in the supine position that we have to look in some different locations, right? Because even though the air is rising, the air is not going to be in the apical position here. It's going to be in the anterior position, right? So we have to look down low there at the base of the chest next to the heart, or on the other side, the base of the chest next to the heart. So one thing that I want to point out is how much deeper this sulcus there looks on the left, like that. There we go. The other thing that I want you to notice is how much more lucent or dark that base of the chest looks relative to the other side. And to really sort of take that in, I think that we should zoom out a little bit. Now, why would I zoom out? Everybody thinks, well, I want to see something better, I zoom in, right? Well, there is a tactic in radiology where sometimes it's better to zoom out. Why? Symmetry. Symmetry is better seen when you zoom out. So I'll show you an example here. So look at this. So just look at this shape here. Just look at that for a second. Okay? I think that looks pretty symmetric right on each side. Now when I zoom way out, maybe here you can appreciate that sort of yellow part there is skinnier than the red part on the other side. I think that's easier to see when it's small. You may also notice that this area here looks a little bit more gray, and this looks just a little bit more white. Again, I think that's a little bit easier to see with stuff small, sort of like my eye can take it all in at once, as opposed to like having to pan my eye to one side and then pan my eye back to the other. Like compare right, compare left, compare right, compare left. If you can make it small, you can look at it all as a single unit. It's just easier to see symmetry like that. And this is useful on a lot of different imaging modalities. So, here we go. We're trying to compare the right side to the left side, which one looks darker. We make it a little bit smaller, and I think that you can appreciate, hopefully, that part there in the yellow box is darker looking than that part there in the red box. So already our suspicion is high. And remember that some of the appearances here, we can see sort of darker there, right? Darker there. That deep sulcus, which I think we've got a little bit of going on here. So sort of going back. Now here's another case, same situation. It's a pediatric case, obviously. And again, this is in a supine study. And, we're going to compare symmetry. So zoom out. And there is actually quite a bit of lucency there on both sides at the bottom, especially if we compare top to bottom. That bottom part is much more lucent. So if we zoom in here, you can see that sort of that area there, right? Too much, dark, too much. And this is, this is a situation clinically where this patient was at risk for pneumothorax, and sure enough has bilateral pneumothoraces. We're picking up here on the anterior or on a supine study. All right, now let's talk about some mimics. Remember, not everything that looks the same is the same. In radiology, we call these mimics. So I've talked about a few of these in the past lectures. I'm just going to try to review these rapidly and then spend a little bit extra time focusing on the primary pretender. The primary pretender. So here we go. So prior talk, we talked about this thing here, this extra soft tissue stripe that occurs along the upper edge of the clavicle. And you can see it sort of here and there, and we call that thing a companion shadow, right? It's often seen right here in the upper ribs. I'll zoom up here. So if we look right underneath of there, we can see that. Be another one here. We can zoom up, make it see it a little bit better. Right there, boom. You can also see them on the lower ribs and sort of axillary portions of the lower ribs. Supposedly, what this actually is. So we'll zoom in here. Again, from this is all sort of review from the prior talk, there and there. That this is supposed to represent like the fat and the muscle along these intercostal spaces caught at just the right angle. So the reason, again, to review this is that this is not a pneumothorax. This is a normal part of the anatomy that we're seeing that looks like an extra line just sort of because of the angle that the radiograph is being shot at. Another thing that we discussed as a possible pitfall here, or mimic, is so sort of like we're looking, we're windowing, and we notice there's a line right there, right? That thing. We see it sure enough. What is that? Is that a pneumothorax? But if we trace that out all the way around, that actually, that's the scapula, right? So the border of the scapula can mimic a line. And, if you're thinking to yourself, lines are pneumothoraxes, especially in somebody who's predisposed to get one, you may falsely call that. All right, so now I want to talk about the primary pretender, the main pretender, the chief mimic for the pneumothorax. So, got a case here, zoom in. All right, we're talking about this guy right here. How do I know that that is not a pneumothorax? This guy. Looks like a line, right? Looks like a line. Okay, so let's review real quick. So remember I used this diagram previously to sort of review some anatomy. Well, now I want to use it to do a little bit of an experiment. What we're going to do is we're going to change this to grayscale. And, we're going to do an experiment, so we're going to need 2 of them. And I'm going to cartoon in the skin here, just so we can see that. Makes it a little bit easier. I'll cut this in half. We only need half to do this. I'm going to put the film behind the patient, and I'm going to pass some x-rays through. And we're going to see what happens sort of at slice per slice. So bring the center of this up here. Now I'm going to give one of these patients a pneumothorax, and I'm going to give the other one a big skin fold. All right, so let's do that. All right, so he gets a pneumothorax there, and this other guy's got a skin fold right there with the red arrow. All right, see that? So pneumo, skin fold. All right, now let's see what happens. We'll put some x-rays through here onto that film, and we'll sort of look slice by slice what happens. We'll start with the pneumothorax guy. So sort of everything over here, we'll just make that black so it's not confusing. First cut here, that's primarily soft tissue through the heart and the hilum, so that's got soft tissue density. And this portion here is more of the lung, that's the collapsed lung, partially collapsed lung from the pneumothorax. And then we'll zoom in here. I'll get rid of this line just so it's out of the way. And remember that the pleura has a thin pleural, that's the edge of the pleura there, that's that pleural line. So we're actually going to see that. We've talked about that, how important it is to see that. And then this last slice, that's the hyperlucent air, the air that's in the pleural space. And then the last one here is just this, the extra skin and meat along the side of the chest wall. So this is a pneumothorax. We've got soft tissue, heart and hilum and that kind of stuff. We've got our lung that's partially deflated. We've got that thin pleural line. We've got hyperlucent pleural air, and then we've got the rest of the soft tissue of the chest wall. Now I want to contrast that to the other side, the guy with the skin fold. So again, sort of black this part out. And then, this right here, that'll be our hilar and heart mediastinal tissue density. This right here will be the lung, and I've drawn that line strategically because of where our skin fold is. And then on the skin fold, it's going to create like a gradient where like the skin that's lumped up is going to block more x-rays, and then it's going to block less x-rays where it's sort of stretched out like that. So like more skin, it's a lump of skin, and then it's slowly grading out like thinner stretched skin. That's sort of what a skin fold does. A folded bed sheet or blanket could cause a similar appearance, like a lump that sort of has a gradient then on the other side. And then it's going to return back to the air that's within the lung, so it's going to look the same as it was before the skin fold, and then chest wall density, and then air sort of at the end. All right, so we'll sort of look at these things side by side, bring them in closer together, maybe stack them so like this, something like that. Now, cartoon in, like we were looking at a radiograph, zoomed up, the guy with the pneumothorax here. I'm going to point out, like, that's the critical line, right? So you see that pleural line, that's why we see that, and that's the most important feature. as opposed to our friend over here with the skin fold, it's not a thin line. Instead, it's a gradient, where we have a lump of tissue, gradient or blanket, and then moving out into, returning back to that regular density, and then lung on the other side. Okay. So, pneumothorax, white line. Skin fold, gradient. All right, back to our case again. Okay, sure enough, there it is, right? That thing. Let's get a zoom in here. Blow that up. All right. This was the schematic that we had for our skin fold. Sure enough, there. Can I convince you that that is a gradient and not a thin white line? So this is a skin fold. So side by side. Sort of stare at that for a second. I think this is maybe the most helpful slide in this talk. Just sort of seeing that pattern recognition, thin line, real crisp, sharp, thin line versus a gradient there with the skin fold. All right. Now, back to this case. Let's say that, man, you just don't feel comfortable. Maybe you don't have enough experience, or the pretest probability for this patient is very high, and even though you're pretty sure that's a skin fold, you also don't want to miss a pneumothorax. It could get a lot worse, cause problems. So what if you're not sure? What do you do? What's the next step? Well, we can go back to this. Remember, this is a tool that we used in prior talks. We talked about air trapping, these kinds of things. So again, the lateral decubitus is useful. So got the patient on their side. This is the same patient, and we're zooming up, and it's gone. It's magic. So in the lateral decubitus, it won't make it harder to see. In fact, it will make it easier to see. So if you get a lateral decubitus and it's not jumping out at you, in most situations, especially with an adult patient, you can feel pretty comfortable that it's gone. It's not real. Another case here, notice we've got a deep sulcus, right, on that side relative to the other one. So we're worried that this is maybe got himself a pneumothorax. Notice that this film is labeled semi-upright. Remember that I said that in prior lectures that semi-upright should be treated essentially as supine, because they could be just 5 degrees elevated and still be labeled semi-upright. So back again to our decubitus, and just reviewing again, this was from the prior lecture. The idea on the decubitus is that the air is going to rise, right? So you would expect it to redistribute laterally along that chest wall, depending on which side it is, which side you have up. So something like this. So it's going to rise to the highest part of the chest wall that it can get to in that position. All right. So here's an example. Also, it's a pretty good one. And again, you can say, boom, right there. You can see that very well. And extra lucency right here. So sure enough, that is positive. That's what positive would look like. Here's a more subtle case, pediatric. This is where we're going to look, right? That's where we're going to look. If that's the side that we're interested in, we zoom way up here, really close to the line, and I feel like I see some extra lucency right here. Now, this is a very small one. It's probably not clinically important, but you could definitely be aware that it's there, close follow-up, and you can see how this really does improve your sensitivity. All right. Now, there's one last thing that I want to discuss, and I sort of saved the best for last, or at least the most important thing for last. Now, the first thing you may be noticing here is how dark that right lung looks, right? Very dark, too dark, especially when we compare it to the other side. So, right there, like that, too dark, right? So, remember, just as a practice tool, if we want to compare symmetry, it's sometimes useful to back it out and make it small. So if we're comparing side to side, we can see one side's certainly darker, right, than the other. So bring this back in here. All right. Now, the next thing you may notice is this. What is that thing, right? almost looks like a mass, right? That's actually the lung totally deflated and collapsed. So this is a large pneumothorax. It's basically the whole lung is collapsed. But I want you to notice some other things here that are pretty important. The other thing that I want you to notice is that things look like they're shifted or they're pushed in that direction. The heart and the trachea sort of look like they're pushed over in that direction. So why is that happening? Well, let's just sort of schematically imagine that you've got a box here and you put a hole in that box, and because that box has a hole in it, air can float in, move around as it wants to, and then maybe float back out also as it wants to. Let's imagine that instead that we have a different kind of tear, got a sort of a tear like this, and what that does is it creates a little bit of a valve or a flap, and that flap allows air to come in, but because of the way that it's torn like that, it has trouble getting out. So over time, more and more air sort of accumulates in there, and as that's happening, pressure is building up, it's building up, and you can have some squeezing there, some extra pressure, and that extra pressure can squeeze some important things like the inferior vena cava. It could stop blood return back to the heart, and that's why this is so serious. So we've got a picture that looks like this. There are a couple of findings that you have to look for when you've got any pneumothorax, but especially a large one. Shift of the heart and mediastinum, shift of the trachea. And I'll point out that two of the cardinal features, especially sometimes in the supine study, you may not see that. Instead, you want to look for this right here. You want to see, if you see depression of the diaphragm, that is happening because there's extra pressure there. So not just pushing the heart and the trachea over, it's also smashing that diaphragm down. So that, again, can be a key. So if you see a large pneumothorax, even if the heart is still sort of centered in the midline, if you see that diaphragm getting pushed down there, that's tension physiology. That means there's some extra pressure in there, not just on the diaphragm, but on some of the blood flow potentially returning to the heart, which can be very serious. And obviously this has to be addressed with a chest tube sooner than later. I hope you enjoyed the lecture. If you'd like to see more lectures like this, you can go to teachmechest.com. Sign up for a free 7-day trial. This free trial gives you full access to the website, where you can find more than 30 didactic lectures similar to this one on all the topics you need to master interpretation of the chest X-ray. In addition, the free trial also gives you full access to more than 50 cases with the IRAD platform. Go to teachmechest.com now to join the radiology revolution.